At the end of this lecture, you should be able to explain the MSSCV assessment when troubleshooting a patient on a ventilator, adopt a patient, machine, or in-between approach to assessing the patient, suggest differential diagnoses and an early management plan for a ventilated patient with high airway pressure, hypotension, desaturation, or dysynchrony. Before we start, I want you to spend a minute thinking about the question on the slide. Before talking about specific ventilator problems, I want to outline the approach to troubleshooting mechanical ventilation. As with all ICU problems, one of the first priorities is to determine the urgency of the situation and to determine if the patient requires immediate resuscitation. Look at the patient and check chest movement. Is it moving and is it symmetrical? Saturation, breath sounds, and cardiovascular status. The next step is to diagnose the problem and to work out whether it is a patient problem or whether it is an equipment problem. This is most easily determined by disconnecting the patient from the ventilator and manual ventilating him or her. If the problem persists, it is a patient or ET tube problem. If it is eliminated, it is a ventilator or circuit problem. Of course, in order to deal effectively with ventilation problems, it is essential that you have a good understanding of how your particular ventilators work. The same ventilatory mode may differ from manufacturer to manufacturer and between different models of ventilator from the same manufacturer. For example, volume control is slightly different in the Siemens 900C, 300A, and Servo I ventilators. High airway pressure is an important problem because of the risk of barotrauma, because the development of high airway pressure indicates a deterioration of the patient's condition, and because it may lead to inadequate ventilation. With most ventilators, the ventilator inspiration is terminated if the airway pressure reaches the set upper pressure limit. As this usually occurs relatively early in inspiration, this results in the patient receiving a much lower tidal volume. This is illustrated on this slide. The first two breaths are normal volume control breaths. On the subsequent breaths, the airway pressure reaches the pressure alarm limit, causing the ventilator to terminate inspiration with a resultant fall in airway pressure, but a reduction in tidal volume. So is the problem in the patient, in the machine, or in between? This is most easily determined by disconnecting the patient from the ventilator and manually ventilating him or her. If the problem persists as a patient or an ET tube problem, if it is eliminated, it is a ventilator or a circuit problem. Remember that the airway pressure is measured in the ventilator, not in the patient's airway, and so a high airway pressure may be due to a problem with the ventilator, the circuit tubing, or with the patient. Occasionally, high airway pressure is due to ventilator malfunction, but more commonly it is due to inappropriate settings. Remember that the peak airway pressure is determined by flow times resistance plus volume divided by compliance plus PEEP. Therefore, an excessive tidal volume or an excessive flow or an excessive PEEP will result in a high airway pressure. In many ventilators, flow is determined by the inspiratory time. An excessively short inspiratory time will result in an excessive flow and hence a high airway pressure. The cause of the high airway pressure may also be obstruction in the ventilatory circuit. This is most commonly due to water pooling in the circuit or to a filter that is filled with water. Note that the obstruction is often in the expiratory limb of the circuit, which results in increased PEEP and hence airway pressure. If the problem is not due to a ventilator or circuit problem, then it will be due to a problem in the ET tube or the respiratory system. Returning to our lung model, we can see that the problem may be a problem of high resistance, low compliance, or both. High resistance may be due to kinking or blockage of the ET tube or due to bronchospasm, while low compliance may be due to decreased parenchymal compliance due to parenchymal disease. Decreased pleural compliance, for example, due to a pneumothorax, decreased chest wall compliance, for example, due to the patient fighting the ventilator, or decreased ventilated lung volume, for example, due to a lobar collapse, or an endobronchial intubation. If the cause of the high airway pressure is not clear from examination of the patient, it may be helpful to measure inspiratory pause pressure to determine the relative contribution of high resistance and low compliance. From our model, it can be seen that when flow is equal to 0, the pressure change between point A and point B must also be equal to 0. So at the end of inspiration, when there is no flow, airway pressure is equal to alveolar pressure. Thus, an estimate of alveolar pressure can be obtained by measuring airway pressure during an end inspiratory pause. Press the inspiratory pause button on the ventilator and read the inspiratory pressure from the display after a few seconds when it falls to a plateau. If the problem is one of high resistance, only the airway pressure will be high. If it is one of low compliance, both the alveolar and the airway pressure will be high. Okay, we're going to pause for a minute while you think of two important learning points from the lecture so far and why they are important. Hypotension. One of the major causes of hypotension following initiation of mechanical ventilation is relative hypovolemia. This is revealed when the positive intrathoracic pressure resulting from mechanical ventilation further reduces venous return and hence cardiac output. The problem is further exacerbated by the vasodilatory and myocardial depressant effects of drugs used to induce anesthesia and allow intubation and ventilation. Fortunately, these effects are usually short-lived, and in most cases the hypotension responds to fluid infusion. Dynamic hyperinflation due to gas trapping is less common, but nevertheless an important cause of hypotension. Gas trapping occurs if there is insufficient time for alveoli to empty before the next breath, and may occur as a result of over-enthusiastic manual ventilation of the patient. It is more common in patients with asthma or chronic obstructive airways disease who have an obstruction to expiratory flow. The net result is progressive hyperinflation of the lung with a corresponding increase in pleural pressure. This results in a fall in venous return, and if severe enough, can result in cardiac arrest. The simplest way of diagnosing and treating this problem is to disconnect the patient from the ventilator. The diagnosis is confirmed by an immediate rise in blood pressure. Finally, always consider the possibility of tension pneumothorax. Although this is a relatively rare cause of hypotension following the initiation of mechanical ventilation, it's important not to miss this diagnosis as it is both life-threatening and easily treated by needle thoracostomy. Desynchrony. There are a large number of causes of patient ventilator desynchrony which need to be considered. It's important to identify and treat these causes and not simply to sedate the patient more heavily. As well as all the possible causes of agitation, there are a number of ventilator parameters which must be considered. These include the mode of ventilation, the IE ratio, and the mode of triggering. In general, spontaneous modes are more comfortable than control modes. The IE ratio is also important, with IE ratios that are similar to the 1:2 ratio of a normal breathing pattern being more comfortable. Flow triggering tends to result in greater synchrony than pressure triggering, and in general, a more sensitive trigger setting is better. If the patient's having difficulty triggering their ventilator despite a sensitive setting, consider the possibility that auto-PEEP due to dynamic hyperinflation is the problem. If no easily reversible cause of desynchrony can be found, it may be necessary to increase sedation. If a patient desaturates while on a mechanical ventilator, it is important to consider both patient causes and equipment causes. Increase the inspired oxygen concentration to 100% and quickly check the patient's chest is still moving before going on to a more detailed examination. If the chest is not moving, it may be a problem with the ventilator, but this is unusual. In this situation, the patient will be easy to ventilate manually. If the chest is not moving and the patient is not easy to ventilate, then the problem is similar to a high airway pressure problem. More commonly, the chest is still moving. A detailed examination of the chest should be carried out, looking in particular for endobronchial intubation, pneumothorax, collapse, pulmonary edema, and bronchospasm. In addition, patient ventilator desynchrony may result in desaturation. Write down 3 key learning points from the lecture, 3 things you think would be important to tell your colleague who did not hear the lecture. I'll give you a minute to do this. In summary, the most common problems on mechanical ventilation are high airway pressure, hypotension, desaturation, and desynchrony. Always look at the patient first. Try to distinguish between a ventilator problem, a circuit problem, and a patient problem, and have an algorithm for dealing with common problems.